We're going to do it. All righty. Thanks, sir. Thanks for the help. Now, if I can get this to work. So, that's me, in case you didn't know. Okay. You got to get this. So, just a couple of quick things. I don't know why. Why doesn't this work? Anybody, you know? You never use it. I'd hate to be back here. That's the only thing. I don't know if it was charged or not. All right. Let me see if I can. So anyway, we're going to gun through the brachial plexus and different roots, trunks, stuff like that. Just quickly talk about the places where you most commonly have nerve injuries, which is at the root level for the most part, and then down at the branches. Relationships of structures around the plexus, which are important. What the plexus contains, what it supplies. So we're actually going to go through each one of the branches and go over the general rules again. Not a lot of detail, but we're going to do that. And common sites of injuries. Yeah, if you can figure it out, that'd be helpful. You know, a little bit of stuff, and we're not really going to do much with that, attachments or whatever. We're going to do the same thing with the lumbosacral plexus. Not working, huh? Anybody a genius here can figure out how this works? Okay. Real fast, do it. It'll help. I can't get it to do anything.
The battery seems okay, but
it does, doesn't it? Come on, quickly. Should have been done by now.
That's something else.
Let me Can you figure out why the remote mouse, I know you can, why the remote mouse in the large auditorium isn't working? I can't get it to do anything. I hate that. Bring in the man. It seems to be charged.
Yeah, it's not problem. Have something that's better for us. Can we get in?
Well, if you can, because it drives me nuts to be back here.
Yeah. And it might be more reliable. I'll be right back.
Okay. All right. Thanks. Okay, you got it? You got it? So where is the brachial plexus in this grand scheme of things? So let me see if I can use this. So we know what the story is, right? We've got the brachial plexus that's coming out of that area. Can you see that little circle? So brachial plexus is coming out of the cervical vertebrae in there, passing through the neck, right? So we're going to get the roots, right, that are going to be coming right out of the specific regions associated with the vertebral column. So then they're going to come together. We're going to eventually have the trunks up here, and then the cords right in this region, and then the individual branches as we head down. So it's important to have a sense of where this all happens. So here it is, kind of opened up. So the pec major is cut away there. And so the question is, what are the components that we have in this particular area? So I've got a bunch of arrows that are going to come up. And so you're going to tell me what that is. Anterior scalene. Okay? Somebody else has to answer other than just Davidson. Okay. So there's anterior scalene. There's C5, C6, C7, C8, T1. T1 is just above the artery, usually. Sometimes it can be behind it. So from a clinical perspective, sometimes T1 is hard to find. So that's that story. So here's another arrow. What's that arterial structure? Is the subclavian artery. And so we know the artery is similar to the branches of the brachial plexus, the roots of the plexus. In other words, just posterior to the anterior scalene. And that relationship is important. So again, the subclavian artery inferior to the roots of the plexus, and then posterior to the anterior scalene muscle. So then we've got a vein there. What's the vein? Subclavian vein, and the subclavian vein is anterior to the anterior scalene. So the artery and vein are separated by the position of the anterior scalene, and they're right behind the clavicle, as you can tell in that particular view. And Kevin's still trying to. Kevin's going to take over the rest of this lecture for us. So what's that arrow pointing to? The axillary. So now it's become the axillary where? We got it working. That's all I got to do is. So, thank you, sir. So now we've got, we've jumped ahead here. Can't do that. So there's the axillary. Once it crosses rib 1, right? Everybody okay with that? It becomes the axillary. And the vein's been cut away, so the vein is still in the kind of an anterior location. So then, whoops, I'm going the wrong way, I'm sorry. So there's the lateral cord, lateral to the axillary, right? And we're going to be going back over the plexus itself in just a second, just to get you oriented. And there's the medial cord. Medial cord is medial to the axillary artery. Where's the posterior cord? So you don't see it here, right? So it's hidden back there. Again, that's an important relationship clinically, which you'll worry about when you get there, especially if you're doing anesthesia. So let me go back here. And then your very important relationship, you can see the M there that leads to this guy, which is the median nerve. Okay, so we're doing pretty good so far. So here is the plexus, and you all drew it correctly, I assume. I'm going to collect those papers and grade them, and your gross grade will be adjusted accordingly, upward or downward. So C5, 6, 7, 5, 6, pardon me, form the upper trunk. I forgot I changed this yesterday. So form the upper trunk. So again, superiorly located. So you can have upper trunk lesions that affect 5 and 6, or specifically 5, 6 lesions. So those are the kind of lesions that increase the angle between the shoulder and the neck. So that's an upper trunk, traditionally upper trunk lesion. I've got a question a little bit later about how that appears, so we'll leave that for now. C7 by itself, middle trunk. C8, T1, lower trunk. So lower trunk lesions are you're falling out of the tree and you grab the branch and it stretches the lower components. And what's that called? That's Klumpke's. So what's an upper trunk lesion called? Erb's, okay? Erb's palsy, Klumpke's palsy. Klumpke's looks a lot like an ulnar nerve lesion because C8 and T1 go into the ulnar. So there's all of that, looks like ulnar, plus a few other things. So that's those guys. Then we've got the posterior divisions that all come together and form the big posterior cord that we couldn't see because what's in front of it? What's right here? The axillary artery. So the artery isn't sitting in anterior to that, so you can't see it. But we know the posterior cord has components from all spinal segments because it's formed from the posterior divisions of each one of the trunks. So then the anterior divisions from the upper and the middle trunk come together and they form the lateral cord, now lying lateral to the axillary. So again, the terminology changes as the anatomical position changes going into the extremity. And then from the lower trunk, the anterior division of it forms by itself the medial cord. And again, relative to the position of the artery. So, back to this guy. So there is, again, our anterior scalene. And what's that? Also on the anterior surface of the anterior scalene. That's the phrenic. That is a very important relationship as well. So those relationships I talked about relative to the anterior scalene are important relationships. Very, very critical to know. So phrenic comes from C3, 4, and 5. So 3 and 4 from the cervical plexus, 5 from the superior root of the brachial plexus. So that's that guy. And again, what's medial to right there, that line that I just drew? What region are we talking about? So those are the roots, okay? So the next region is, so that's where the trunks are. You can see upper, middle, and lower trunk, right? Everybody okay with that? So the next region would be that's the divisions. So we talked about those and how they come to the next component, which are the cords. So those are the components. Again, most of our brachial plexus injuries are at the root trunk level, right, proximally, because of what we just talked about, the stretching of those components. And now, when we're in this region, not a whole lot of injuries that do occur. They would be more trauma kind of things. So, crushing the clavicle can do damage, all kinds of goofy things with automobile collisions, etc. So, then we get into our branches. So, the question of where is the C8 root is, which one? D. All right. So, got a little bit of D there. Okay. Trunks. Trunks of the plexus are? It's okay to answer. That's kind of why I did this. So there's B. Okay? So that's pretty basic stuff. But there are images on as you know, on your subject exams and certainly on step 1 when you eventually get there. So this then shows you how we get the individual branches, and we're going to be going over all of those. You know positionally where these things are. You can get to, for example, the median nerve right here, as it travels right along with the artery. You can actually put pressure on the median nerve, the ulnar nerve just posterior to it. You know the ulnar nerve at the elbow, the most commonly injured guy. Median nerve right here in front of the cubital fossa, fairly commonly injured there. And then as we come down into also, I forgot the radial nerve over at the lateral epicondylar level. So we're going to talk about the places where these things are most commonly injured as well. So here's one of them, there's one of them, there's one of them, there's one of them. Then we get down to the wrist. We know about carpal tunnel syndrome. You know the ulnar nerve is here. What's sitting right here? Recurrent branch of the median. Good, you do remember some stuff. Okay, so we're going to be going over all of that stuff as well. So, some of our general rules. What's that guy? What is it? Axillary. How many of you are in here? Why did I only hear medicine? You know? It's okay if you're wrong. there's a greater chance you're going to remember it if you make a mistake here and there, although I don't expect you to be wrong. Spinal segments, axillary. How do you know? Shoulder, right? Even though it's coming off our posterior cord here, which we know has all the spinal segments, we know that's 5 and 6 because shoulder, all right? So you remember that, that's good. So 5 and 6. So there is our axillary. Where's it coming through? Do you remember that? So it's coming through the quadrangular space along with the... Yeah, Heidi's happy she got that one. So with the posterior humeral circumflex artery. So they travel there. Very much at risk during what kind of injuries? So shoulder dislocation, that's one of them. What's another one? Where is that nerve relative to stuff around it? Surgical neck of the humerus. So surgical humeral fractures, shoulder dislocations, this guy is very much at risk. So gets the deltoid and teres minor, only those two muscles. But you know that the deltoid is very important because it assists with every action at the shoulder, every single one, right? So that's why it's so important. Teres minor is, in fact, pretty minor in that regard. Cutaneous, lateral shoulder. Remember that? The skin over the deltoid? So that's that gray area there. Skin over the deltoid is also supplied by the axillary. Okay? So if you got somebody, shoulder dislocation, numbness here, you know what's happened. Weakness with every action. Okay, so our next guy is this guy, which is that's the radial. So spinal segments in it, all of them. So C5 to T1, so that's that big guy. And again, travels down. What's the general rule for the radial? Posterior arm, posterior forearm. So we're going to see that all the way down. Muscles and skin, posterior arm, posterior forearm. Very important to make sure you remember your general rules because everything will spring off of it. You know, if you get that, the details become pretty easy. So there it is. Where is that? Where is it? Triangular interval. So there's a triangular interval. The artery that travels with is profunda, or the deep branch of the brachial. So they travel there. So two places right here that it can be injured. There's a thing called Saturday night palsy. Yeah. Madison likes to experiment with Saturday night palsy. So, you know, that's passing out and with your arm over the back of the chair. I remember at our meeting, OSR meeting up in Seattle, I found her like that. It was awful. So you pass out with your arm over the back of the chair, and there is the radial nerve. And so very much there. What about a little downstream? What about right in, what's going on right here, right in this area? So mid-shaft fractures, mid-humeral shaft fractures also can damage this guy. So either of those are pretty high up, right? You're in the axilla, you're proximal here. So those kinds of injuries can affect, especially when it's Saturday night palsy kind of things, affect everything all the way down. Mid-humeral shaft fractures, you might still have long head of the triceps still functioning. So there's our long head because he gets his nerve supply usually a little more before that. So he might still be working. So you might have a little bit of extension at the shoulder with him, a little bit of extension at the elbow through him. But for the most part, your triceps is pretty toast. So that's that guy, okay? And then, again, muscles are the posterior arm, posterior forearm. Our triceps here and all of those guys in the posterior forearm. Pretty complicated, as I'm sure you remember. So the cutaneous, again, similarly, posterior arm, posterior forearm, down to the hand. So this is the critical part, the 3.5 digits on the dorsal side. Remember that? Not the nail beds. All right? not the nail beds. The nail beds get it from the median that go around. Very good. So we got a 17-year-old football player brought to the ED, injury that has likely affected the axillary nerve. So what kind of things might be affected? Damage to the axillary artery, a fracture of the middle of the humeral shaft, weakened flexion at the shoulder, weakened flexion at the elbow. So we got 3 there. Okay. Everybody's all right with that? Okay. So then back to the big radial here. As it comes into the posterior aspect of the forearm, what you see there is, the reason you can see it there is the lateral epicondyle has been cut away. So there's where the lateral epicondyle should be, just posterior to this guy, because the nerve comes around, as you know, comes around and goes anterior to the lateral epicondyle. So very susceptible to injury, lateral epicondylar fractures, trauma to the muscles of that particular region, so tendonitis kinds of problems can affect it there as well. So there's that guy, and then it comes down, as you know, and does all of the muscles of the posterior forearm. So the cutaneous branch is the guy that peels off up here, and it comes back around, so it travels under the brachioradialis, which is what you see up there, and then it comes down and gets the lateral 3.5 on the dorsal side, with paired branches going to each one of the digits, as you see it there, not the nail beds. So the deep branch is the guy. What happens, what's significant with the deep branch? What does it do that's kind of unique? Goes through the supinator, so that's what's happening here. So going through the supinator, and it comes out as the posterior interosseous, okay? So it goes through the supinator as the deep branch supplies the supinator, and we talked about hypertrophy of the supinator can affect this particular nerve, compress it, so that downstream from there, you have weakened action of the muscles that are downstream. What's the first sign of that? Weakened power grip, correct. So what is the power grip? You have to extend at the wrist to give better leverage to your wrist flexors, which are your finger flexors as well. So that's wrist extension. So if you compress this guy, you have weakened power grip. What's the next step in the process if it gets more severe and wrist drop? So it's first weakened power grip, and then you got wrist drop. So that's the sequence, okay? So that's that guy. So there's the posterior interosseous coming through, getting all of the smaller muscles. And there's the cutaneous innervation in pink, posterior arm, posterior forearm, posterior aspect of the hand, lateral 3.5, again, absent the nail beds. So, 17-year-old hockey player, trauma to the lateral epicondyle of his right elbow. You know where this is going, right? Which nerve is most likely affected? Radial nerve. Could be both branches, could be a single branch, depending on where they branch. It's not uncommon to affect one of those two branches, or the parent radial as it's coming down. Okay, the initial finding from mild trauma to the nerve would be, again, loss of power grip, all right? And more severe damage, again, wrist drop. Everybody okay with that? So what's that guy? Yes, it's the musculocutaneous. Yeah, that's what happens when you get old and spastic, you know? Okay, spinal segments in the musculocutaneous would be 5, 6, and 7, right? Comes from the lateral cord. Lateral cord is contributions, anterior contributions, divisions from the upper trunk, 5 and 6, middle trunk, 7. So that's what that guy has, 5, 6, and 7. What does it do? What's the general rule for musculocutaneous? So anterior arm. So there it is, the anterior arm muscles. What are the muscles in the anterior arm? There are 3 of them. What are they? So you got the biceps, which crosses both joints, right? You got the biceps crossing the shoulder and the elbow. So that's that guy, shoulder and the elbow. And what's the other one? What's this guy? Coracobrachialis, and that's the brachialis. What's this guy specifically right up here? What's that guy? That's the long head of the biceps. Do you remember it? Going up and going into the joint space and attaching to the supraglenoid tubercle. Very good. Okay? So that guy is particularly problematic himself, that long head. You're not going to see that on this exam, but still, just as a reminder. Why is the biceps important? What do you know about its distal attachment? What does the biceps do? So it flexes at the shoulder, it flexes at the elbow, and it supinates when flexed. Okay, that's an important thing. So damage to that nerve, which really doesn't happen commonly, but that's a major effect. So what's in green here? That's the lateral cutaneous nerve of the forearm. That's what the musculocutaneous does cutaneously. So anterior arm muscles and skin of the lateral forearm. What does that remind you of in the lower extremity? The saphenous, right? The saphenous nerve that's a branch of the femoral. So we'll see that shortly. Okay? So there is the musculocutaneous, 5, 6, and 7. Goes through the coracobrachialis. Clinically, not much going on with that. It's not like the deep radial going through the supinator. This really doesn't have many problems associated with it. It's not to say that it couldn't if somebody really bulked up or whatever, but it's uncommon. Anterior arm muscles again, cutaneous lateral forearm. What's that arrow pointing to? Median. How do you know? Right in the middle of the M. So that has a lateral branch coming from the lateral cord and the medial branch coming from the medial cord that help form that particular nerve. So what spinal segments would be in the lateral branch coming to this guy right there? What spinal segments are in there? 5 and 6 and 7. 5 to 7. What's in there? 8 and T1. So that's how this guy gets all his spinal segments. So there's the median. Again, all spinal segments from the brachial plexus contribute to this guy. So general rule for it is, so we've just done anterior arm. So if you know, it's pretty easy to remember the specifics of this because you just did posterior arm, forearm, right? You already did shoulder stuff with the axillary. So you did musculocutaneous here, so you're kind of limited where you can go. So now we're doing most of the muscles of the anterior forearm, except for, you remember? Except for 1.5, right? Half of profundus and extensor carpi ulnaris that are supplied by the ulnar. So there is the nerve, and one of the places that it can be injured is right there, anteriorly in the cubital fossa. It can be injured here medially too. You know, if one of the problems that you see clinically is damage to the median and damage to the radial, people that don't use crutches correctly. So somebody that's on crutches with, so you may see that on an exam. You know, people that tuck the crutches up into their axilla, you can get that, you know, same Saturday night palsy outcome with that, okay? And the median can be damaged right in that lower location. So anyway, there's the median. We said all the spinal segments, no branches in the arm. So it does muscles of the anterior forearm except for 1.5, and then it does the important 3 thenar muscles. With which branch? The recurrent branch, and that's an important guy. I told you about Damien, I'm pretty sure. So cutaneous, it doesn't do any cutaneous in the arm or forearm. It's just down into the hand. where it's the lateral 3.5 on the palmar side, and it also does the nail beds. Does the nail beds, so that's what this part is for. So here are the nail beds. So anterior aspect of the lateral 3.5, and then the lateral 3.5 nail beds. So pretty important guy. So there is the recurrent branch of the median. So that's a pretty important guy. What happens if that guy is damaged? So a lesion of that would cause you to have the condition called apand. So what happens with apand? Okay, so you can't oppose, you lose the opponens, and that opponens is the guy that puts the thumb into this internally rotated position. So if you lose the opponens, the thumb is externally rotated. It's in the same plane as the rest of the fingers. And again, you cannot do this. So you have that kind of condition called apand. Okay, good. So there is the, what's the nerve there? Just the median. So that's the nerve. What would you have if it were damaged more proximally? So instead of the recurrent branch down there in the hand, which happens all too often, what would happen if you damaged this guy proximally? So you affected all of the, or for the most part, all of the guys. What do you have? There's a condition that you would have. Aha. Hand of benediction. Exactly. So what happens is you have the individual flex, right? And they can flex these guys, but superficialis is gone. So even flexion with these two is weakened, and profundus to these two is gone. So you end up with this kind of a situation. That's the hand of benediction or papal benediction. It's usually referred to now as the hand of benediction. So, and again, understanding what happens is you ask the patient to flex. Weaken flexion, but they can flex the ring finger and the little finger. They can flex them, but it's weak. Because you do have profundus still coming to these two, supplied by the ulnar, right? And these can't flex because superficialis is gone, and profundus to these two is gone. And you also have apand as well. So, okay? So what's this guy? That's the ulnar. Spinal segments in the ulnar. So we've got C8 and T1, the lower guys coming off that lower trunk, right? And so again, a Klumpke's palsy stretching that lower trunk can mimic an ulnar nerve lesion as well. So here is the ulnar nerve. It's that guy there. Again, we know that it's going to be those two spinal segments. So what does it do now? Goes 1.5 muscles in the anterior forearm. We know that. And the muscles, the intrinsic muscles of the hand, other than our three thenar guys, okay? So it does essentially the rest of the hand muscles. So goes behind that medial epicondyle with the superior ulnar collateral artery. So that's up there, right? So those two travel together up behind the medial epicondyle. So that's that guy. Very commonly injured, the most commonly injured guy in the upper extremity. So you're going to see a lot of that clinically, and obviously a pretty good chance you'll see it on the exam. So the thing that happens here, and the reason it's so problematic, is not only does it go behind that medial epicondyle, so if you have bony fractures or whatever, you got a problem, but also it goes through the tendon of the carpi ulnaris muscle. So you've got that common flexor tendon that has 4 muscles attaching to it. Do you remember that? What's this guy? Pronator teres. What's this guy? What is it? Carpia radialis. What's this guy? Ring finger. Palmaris longus. So some of us don't have that. And then this guy is Carpia ulnaris. So you got that common tendon here, and the ulnar nerve actually goes through the more medial side of that, more towards Carpia ulnaris. So tendonitis there, bad news for the ulnar nerve. And that's a very common problem. So that's what's going on there. Then it travels under the cover of Carpia ulnaris, and it goes through a little tunnel right there called, do you remember? Guyon's tunnel. Good. So, I didn't mention anything about carpal tunnel syndrome. So it goes through there, goes through flexor carpi ulnaris, gets 1.5 muscles in the anterior forearm. We already talked about that, and the rest of the intrinsic muscles in the hand. So all of those guys. And cutaneous, it does, as you can see up there, the medial 1.5 digits on both sides. On both sides. So this branch coming off that you can see right up here, this branch is the guy that goes around posteriorly and gets the dorsal side of the hand, of those 2 digits rather, except for the nail beds. And it's the palmar branches that come down and split and go around and get those nail beds. But anyway, the bottom line is ulnar does both sides of this. So before I don't want to ignore it, let's go back and do. So our median nerve, again, down into the wrist. Carpal tunnel syndrome, right? You're well aware of that. So it's going through there. And remember, it's the branch that goes into the hand, gives off the recurrent branch, gives off the digital branches, gives those off, right? So that's the guy that's coming down into the wrist by going deep to the flexor retinaculum. The branch that supplies the palm goes superficial to it. So from a clinical perspective, somebody comes in, they complain of numbness, tingling, and all that stuff, my hand hurts kind of thing. But you, the all-knowing clinician, can tell that the palm is still functional, that nerve goes superficial to it, but their fingers are numb, tingling, etc. So that's an important distinction. And again, that's the median as it's coming down through there. Also, they would have problems with this guy in that particular case. Okay, sorry about that. So we did this guy. So what do we have if we have an ulnar nerve lesion, whether it's at Guyon's tunnel or proximally? So if it comes, well, let's start up here. If we have a lesion up here, what are the things that would be affected? How would you, if somebody walked into your office and they had a high ulnar nerve lesion, it was toast, right? How would you know? You don't even have to ask a question. How would you know? They got 2 things. They're going to be radially deviated, right? Because carpia ulnaris helps them adduct. So they're going to be slightly radially deviated. And more importantly, they're going to have claw hand. And you can see that as they walk in the door. So that's important. So what are the muscles that this guy supplies that are critical muscles? What does it supply? So it does these 1.5 in the arm, right? So carpia ulnaris and what's the half? Profundus. Profundus to these 2, okay? So if you lose it, then flexion of these 2 is obviously affected, right? So what's the last muscle that the ulnar nerve supplies? The last one that it supplies is the adductor. Remember? Adductor pollicis. And why is that important? So why is that important? Adductor pollicis. So what is, if I can't hold that, what's that called? Froment's sign. Froment's sign. So inability to hold that there is Froment's sign. And that's because of the adductor pollicis, the last guy that's supplied by the ulnar. Okay? So that's one thing. Adduction, Froment's sign. What else does the ulnar nerve supply? Muscles that do that and that. What are these? So these are those are the dorsal. Those are the dabs. What one does this? What does this? Is that a dorsal or a palmar that does that? That's a dorsal. Because that's the axis, that is the axis, and every time it moves, it's moving from its previous position. That's what defines the dorsal. Okay? So when that moves, it's going to be one of the dorsal that's moving it. Okay? And then moving back to the axis, the other three guys, moving them back to the axis, i.e. to the middle finger, are the palmar, right? What else do the interossei do? This is critical. They do this. They flex at the MPs and extend at the IPs. So if you lose the ulnar nerve, you can't do this, which means if you can't do this, instead of being flexed at the MP, you're extended. Instead of being extended at the IPs, you're flexed, i.e. claw hand. So that's how you get claw hand. Hopefully you don't get claw hand, but that's how claw hand is, how it occurs. So there's the guy. Here's the guy coming over to the adductor, and that's supplying the interossei and all that good stuff. Okay? Guyon's tunnel, not too many problems associated with it. It's not like carpal tunnel, but it is going through that space. And so what is next to Guyon's tunnel that is problematic? Which? The hamate bone. The hamate bone is right here. So fractures of the hook of the hamate cause ulnar nerve trauma, ulnar nerve lesion. Okay? So hook of the hamate's right here. So falling on your hands kind of thing can fracture the hook of the hamate, can lesion the ulnar nerve. It's right, actually it's right, well, they don't show it, but it should be right here. Okay, so nerve is and the lesion due to fracture would result in a clinical condition called claw hand. Okay, everybody all right with that? So if you had a lesion more distally and it really wasn't just destroyed, what's the initial sign that you would see of weakness due to an ulnar nerve compression? What's that called again? Froment's sign. So again, this is more proximal. Okay, long thoracic. So we're doing some rule of threes stuff. So there's rule of threes and there's the long thoracic. Long thoracic. If long thoracic is not on here, I will buy you all a cup of coffee at Starbucks. How's that? I didn't say that. Every time I do that, it just turns out to bite me. So what happens if this thing is lesioned? Thank you. Okay, so we know that. So that's winging of the scapula if that happens. So that's it. So that guy up there is the C5 branch to the phrenic that we talked about. And that guy there, do you know what that guy is? That's the dorsal scapular, right? So there's C5 coming off C5. That's the dorsal scapular going to the rhomboids, okay? So that's those guys. that are the proximal ones. And then continuing, whoops, suprascapular, okay. So we've got this more lateral guys, one of which is this guy, which is the nerve to subclavius. Who cares? This one is important, and that's the suprascapular, okay? So that guy is important. And damage to it, to the suprascapular nerve. What's going to happen with it if we damage it? So this guy, again, we know it's 5 and 6 because it's going to shoulder. What's one of the two guys that it supplies? Supra and infraspinatus. And the supraspinatus is the important one, and what does that do? Initiates abduction. So that's important. So then that guy, you know what that guy is? Lateral pectoral. So very good. There's the lateral pectoral. Remember, pec major gets both the lateral and the medial pectoral. So that's 5 and 6. Actually, that should be 5, 6, and 7. Somebody goofed. Going to pec major. And damage to this nerve would result in what kind of things? What's the main thing that it would affect? So flexion, that's the main thing. Lateral pectoral goes to this clavicular head, and the main thing, that's the main action. So the main thing would be flexion, would be weakened. But that is 5, 6, and 7, pardon me. So what are those guys? Do you know? Coming off the posterior cord. Remember, these guys were kind of goofy. They're coming off the posterior cord like the axillary is, for example. And the axillary is only 5 and 6 because it's going to shoulder. But that posterior cord stuff is always kind of goofy. Upper and lower subscapular, good. And what's the one in the middle? The one in the middle is the thoracodorsal. So there's the upper subscapular going to subscapularis. So we know it's shoulder, so it's 5 and 6. It's another one of our rotator cuff muscles. This guy is the thoracodorsal. So that's 6, 7, and 8 going to lat. Okay? So it's traveling out of the neck, coming on down, going laterally, and getting to that particular muscle, lat. And so it can be damaged in axillary surgeries, lateral chest injuries, that kind of thing. So that's that guy. And then, so what would happen if that nerve were injured? How would you know it? What things are affected? Or in other words, what does lat do? So lat does this: internal rotation, extension, adduction, right? Very important for swimmers and doing pull-ups and stuff like that. So I damaged my right one, so now I have to do my pull-ups only left-handed. So it's really annoying. So can't do more than 50 or 60 of them now. And then the other guy is going to be your lower subscapular. So it's subscapularis and teres major, right? So that's what's going on with those guys. And then finishing up our wonderful rule of threes, we've got that guy, which is the medial pectoral. So there's medial pectoral. And it's going to the pectoralis major. Called proofreading. 101. I failed. So there is the medial cutaneous nerve of the arm and of the forearm. So that's what gets the cutaneous stuff. So here are the named nerves as they go to the skin. So the one in green is from the musculocutaneous, so that's the medial cutaneous nerve of the forearm. What's over here in the yellow? There's the median. Okay, what's over here in the blue? What's up there in the gray? Okay, and then on the back side, we got the same kind of story. What's the red stuff coming down? So those are all the branches of the radial. Okay, dermatomes. Dermatomes are really important. So we've got the named nerve, cutaneous contribution, and then a named nerve is formed by the fibers from more than one spinal segment for the most part. But they don't distribute those fibers equally throughout. So you don't get like 5 and 6 here and 8 and T1 there. You get them separated off into that dermatome pattern. And that's because, if you remember, developmentally, we have a limb bud that forms here. And C5, C6, C7, C8, and T1 come in there, into the limb bud, etc. They grow in. And then you take the limb and pull it out to the adult position, and those individual spinal segments, so just like the thorax is segmented, so was the upper extremity. But when you pull it out, they kind of get distorted a little bit. But it's still there. That spinal segment pattern is still there. Now, what happens is the nerves get combined into the branches of the brachial plexus. So those spinal segments creating the dermatome pattern are kind of wrapped up together, and then they get separated off into the specific regions that this occurs. And I know for some reason this causes a lot of problems. How can the such and such nerve be this, and it goes there, and it distributes this? But that's the basic story. It started as a segmented entity. It's still cutaneous distribution, just like the chest wall, is still segmented. It's just that they get carried by named nerves that get wrapped up together. So, let me clean that up. And there we go. So testing a single spinal segment is important. So you have to know where these guys go. So that's real simple. C5 is anterior shoulder. Again, it's carried by the axillary, but C5 gets distributed here from the axillary, through the axillary, by the axillary, okay? And then C6 goes down to the thumb. Doesn't mean there isn't C6 elsewhere. You see a little bit over the shoulder, right, by the axillary. But again, when you're testing these, you want to separate those, the furthest part, from other guys. And the further distal you go, the easier it is to separate them from the adjacent guys. So go distally. So in other words, the thumb is C6. The middle finger is C7. The medial aspect of the hand and little finger will be C8. And then back up towards the axilla is T1. So if you've got an injury that's causing numbness, paresthesia, etc., in a specific region, you got to know this. And it can help you. And I told you my son, when he got kicked in the side of the head, and thumb was numb, and bam, it's a C6 injury. It's that simple. So that's that. Motor function. How do we test for C5? Good. How do we test for C6? Good. Flexion at the elbow. So abduction at the shoulder is C5. Elbow flexion is C6. What's C7? Elbow extension. You remember something. Good. I'm proud of you. And C8 is finger flexion. And ab adduction is T1, right? And so that's going to be, like I said, T1. So anyway, that guy's in the way. So C8 and T1, flexion, and then ab adduction, or what I say. Flexion is C8, and T1 is ab adduction, okay? Real simple. So if you've got somebody that's got numbness of the thumb, like my son did, you would expect weakened elbow flexion, right? So those things together. And again, they're carried by the named nerves, but they get distributed to different regions, i.e. the cutaneous distribution, and they also get distributed to the muscles differently. So we say anterior forearm muscles are by the median nerve, but to be honest, all muscles don't get all of the spinal segments carried by the median. They get specific ones, but we don't go into that kind of detail. If you become a neurologist and want to do specific electrophysiologic testing, you will learn that. There are charts for that. So that's kind of pointless. So that's that. Compound fracture there, which would affect what? Whoops. Ah! Sorry about that. Well, that's curious. So, what's the answer here? Radial. So the radial, down there, the guy I tried to cross out or something. I don't know what I was doing there. So that's that guy. All right. So we got a 12-year-old brought to the emergency department, skateboarding accident, fell while trying to ride on the stair rail, landed on his left shoulder, left side of his head, right? Shoulder, head, that thing. His left arm tends to hang limply along the side, internally rotated at the shoulder, palm is pronated, unable to abduct, right? X-rays are negative. What's the lesion? What is this called? This is herb, right? This is classic herb. And herb is what? Upper trunk of the brachial plexus, okay? Good. So, what's going on here? So we got a little bit of thoracic outlet syndrome. What are we going to have? What kind of symptoms are we going to have here? What do you think you'd have with this particular patient? So what's causing this? Cervical rib. You got a cervical rib. So what kind of things are you going to see in this patient? If they just had this? Blood flow problems, decreased flow. The right extremity gets tired, weak, cold, right? All of those things. Reduced blood pressure to the right upper extremity. Pretty easy to compare one to the other. Remember, that's what you do, one side to the other side. So it's all due to reduced blood flow. So if he just had that. What sits right above this? Right there. Brachial plexus. So it's likely that the plexus is also affected. So here is the brachial plexus, right, with the artery removed. So the lower trunk of the brachial plexus could also be affected, could be stretched, could be compressed. So those things we talk about with the ulnar nerve and everything like that, weakness associated with ab and adduction, for example. That's, you test. So the two things you would test is Froment's sign and ability to squeeze the fingers in comparison to the other side, or separate the fingers. It's usually easier to test squeezing. Okay. So we're doing okay time-wise. Lower extremity, you want to just drive on? Run through the tape, you idiot. Okay. So here we have lower extremity. Remember, putting your hands on the iliac crest leads you to the spinous process of LV4. Very important relationship, okay? So that's critical. Where does the spinal cord end? Spinal cord ends at LV1-2. So spinal cord would end above this. This is a good landmark, so if you got to find L4 and you got to get in there, LV4, and you got to get in here and do a lumbar puncture or whatever, that's a safe place to go. All right? Everybody okay with that? Baby is going to come down lower. So if it's LV1-2 in the adult, could be a little higher, but it's safe as LV1-2. Baby is LV3-ish in some cases, a newborn. Premature could even be lower. So what's down there? What's this arrow pointing to? It's another landmark. What's that pointing to? No? Got you all, huh? That's a sacral hiatus. So you can actually get to the epidural space by going in through the sacral hiatus, and you don't have to, if you got somebody that needs epidural anesthesia and they really can't bend over, they're not very mobile, or they've had trauma of the vertebral column, this is an easy way to get there. Okay, here is the lumbosacral plexus. So got a mess there. So there's T12, right? What's that called? T12. What does that give rise to? Okay, we'll get back to that. L1, L2, L3, L4. There's L5, S1, S2, S3. Right? So that's these guys. So T12 is subcostal, under the 12th rib. Gee. Whew. Dentistry. Pulling teeth. L1 gives rise to iliohypogastric, ilioinguinal. Okay? Those two guys. Ilioinguinal goes and becomes the anterior labial, anterior scrotal nerve, sensory down to that region. Iliohypogastric is suprapubic region, sensory there. Okay, that's lateral cutaneous nerve of the thigh, lateral femoral cutaneous. That's its only job, lateral aspect of the thigh. Okay? What's the next guy here? This big guy here. Oh, come on. Femoral. Okay, so there's the femoral right there. So there's, oh, I forgot genitofemoral. How would you identify genitofemoral? What's the significance? What's the easy way to identify it? How do you find it? That is what it does, yes. How do you find it? Okay, we'll see it later. So, do you know what this is? Here's L5 and S1 coming together. You know what that is? That's the lumbosacral trunk. It's half of L5, about, and all of S1. And it comes down over the sacrum and heads down in and forms sciatic, etc. So that's L5, S1. So there's the obturator, like the femoral. It has L2, 3, 4 in it. So it's going to the medial, and we're going to go back over these. So there's the obturator, and then there's the big sciatic with its tibial component and its common fibular component. Okay? So those are all the guys that we've got coming into the lower extremity. So over on the right is kind of what you just saw, and over on the left, it shows you some of these guys. For instance, this guy right here. What does that happen to be? Genitofemoral. How do you know again? Comes out through the psoas. What's on the lateral side here of the psoas? Femoral. What's on the medial side of the psoas? The obturator. Okay? So, and lateral femoral cutaneous is the guy coming out right next to the anterior superior iliac spine, going under the inguinal ligament. Okay, so there we have the lateral femoral cutaneous, L2, L3, and it's going to that pink area. So that's what it does, goes to the pink area. And that's it. Okay, it's not a branch of the femoral, but that's the important thing is to distinguish it from the femoral. The femoral does the rest of the cutaneous innervation of the thigh, except for the lateral part. So, again, those things show up on exams. So there's the femoral, L2, 3, 4 on the lateral side of the psoas. And from a cutaneous standpoint, it's doing the blue stuff. So we have that guy there, medial and intermediate branches of the femoral. So the anterior thigh is femoral, femoral, lateral femoral cutaneous. Okay? And that is significant. So what's down here? What's this? So that guy down there, so there's the medial, there's the intermediate. That guy down there, again, is the saphenous. So that's down to the medial aspect of the leg and foot. That's important. If you don't see that, I would be surprised. So again, because the spinal segment that it brings down to the medial aspect of the foot is going to be L4, and this is the guy that does it, brings that down there. So again, this is, if you will, the musculocutaneous of the lower extremity. So the femoral nerve, L2, 3, 4, supplies the anterior thigh muscles. So the guys that are in that anterior thigh, it's important to know the unique function of those. What do the anterior thigh muscles do at the hip? They assist with flexion at the hip, but more than that. Remember that one particular guy that does a lot of other things? Do you know what's going from there down to here? Sartorius. So the sartorius is attaching to anterior superior iliac spine. It assists with flexion, yes. Also assists with abduction and lateral rotation, right? Remember the Taylor's position. So it then goes down and assists with flexion at the knee, okay? So flexion, for the most part, at the hip, but then the other things that Sartorius adds in. What do these anterior thigh muscles do at the knee? Extend. What else extends at the knee other than those supplied by the femoral? Nothing. Thank you. Only the femoral supplies muscles responsible for extension at the knee. If you lose the femoral, you cannot extend at the knee. Can't do it. Gone. Okay? It's rare to have only one nerve responsible for a major action, but this is the case where you have that. So we already talked about what the sartorius can do as well, which is also assist with flexion at the knee. So, okay? That's what that guy does. So there it is, and there is the saphenous branch, which is, again, important. So, so if you injure the femoral, you lose what? You lose extension. Do you lose flexion at the hip? No. You lose extension at the knee. Can you still walk? Can you walk? Yes, you can walk, and you usually walk, kind of swing out your extremity. You swing it out, you try to keep the leg straight, hit the heel, and take a short step. If you go too far, you will fall off. The femur will fall off the tibia. So a person walks like that. Okay? So there is the femoral, the nerve, coming through the space underneath the inguinal ligament into the femoral triangle, which is what we've got there. There's the femoral artery, there's the femoral vein, and that's where a femoral hernia occurs, just medial to the femoral vein in that empty space. So that spells out, those are included in the femoral sheath. So what we get is navel, nerve, artery, vein, empty space, and the L is for the lacunar ligament, which is a specialization of the inguinal ligament. But that relationship is important. The femoral nerve, most lateral, outside the femoral sheath. Okay? So this is the left side, and shows you the landmarks, the femoral crease, right up, well, left side, right here. And then the femoral artery, which is an easily identified landmark. So if you had to get to the femoral nerve, you just go lateral to the femoral artery, and there you got it. So the next guy is the obturator. Again, medial to the psoas, same spinal segments, 2, 3, 4. He's coming down to the medial aspect of the thigh. So that's him there. He will have an anterior and a posterior division. And the anterior division is anterior is superficial to adductor brevis. and the posterior division is deep to adductor brevis, which is what you see right there. So again, the anterior division is on the top of adductor brevis, the posterior division goes behind it. This is adductor longus that's cut away here. Okay? So, rarely injured, but it could be compressed by an obturator hernia. So a hernia coming through that small obturator foramen right there where the nerve and artery come through. So it does happen. It's rare, though. So there's the space that the obturator supplies, a small area of skin on the medial aspect of the thigh, variable in amount, but that's it. Okay? Then the big sciatic, L4, 5, S1, 2, 3, big guy. All right? And we see him coming out right there, below the piriformis. So it comes out inferior to the piriformis. And again, the sciatic nerve is the combination of tibial and common fibular. And the piriformis can be pierced separately by the common fibular branch. So we'll see that again. All of those spinal segments in here. So, gives rise to the tibial and common fibular, but sometimes the piriformis can be pierced by the common fibular branch. In other words, they don't come below the piriformis as a sciatic single entity. They come through as split components, which they eventually become, right? So, piriformis injuries, which is a lateral rotator. So if you do trauma to piriformis, you can compress the common fibular nerve. What would be the outcome if you compress common fibular? What's the big thing? Foot drop, good. So the clinical condition would be foot drop, if it's severe enough, okay? So to know where the sciatic nerve is you can use sacral hiatus and greater trochanter or the anterior posterior, the posterior inferior iliac spine and then connect it to the greater trochanter. But there are landmarks there. The point is, you don't want to go there. Just to let you know where that guy is, you don't want to go there. So if you have to give an injection, you make sure that you are in the superior lateral quadrant of this guy. So you need to make sure you're way up and away from the sciatic nerve. And it can be complicated by the fact that that common fibular can be a little more superior lateral than the sciatic usually is. So that's why you want to stay way up in the superior lateral quadrant for injections to avoid that. In other words, that's where you want to be. Okay, so that guy is the posterior femoral cutaneous. We had a lateral that was only cutaneous. We've got a posterior that is only cutaneous. Then we've got the sciatic that's coming down, and it gives rise to the tibial and the common fibular. We talked about the suitcase nerve, my term for it. Because this guy is the most commonly injured nerve of the lower extremity. So up in the back of the thigh, all of the muscles, all of our hamstrings up here are supplied by the tibial portion of the sciatic, except for, you remember? Except for this guy, which is the short head. So the short head of the biceps, right? Short head of the biceps femoris is supplied by the common fib. So your true hamstrings are tibial branch of the sciatic, the short head of the biceps that joins with the biceps and comes down to attach to the neck, or pardon me, to the head of the fibula down here. So there's the long head cut, and they come down and they attach over here to the head of the fibula. So that's what's going on in the posterior aspect of the thigh. So then the tibial and common fibular separate, usually down here in the popliteal fossa. Tibia goes straight down, gets posterior aspect of the calf, and then down into the foot. And then the common fibula goes around laterally around the neck of the fibula, and then branches into its deep, goes anterior, and superficial goes to the lateral compartment of the leg, right? 3 compartments in the leg. So again, there's the tibial and there's the common fibular. So gastroc, and then the deeper muscles that we've got in here. So if you ever wanted, if there was anything about a popliteal block or anesthetizing down into the lower extremity below the knee, you can do a popliteal block, and then the only thing else that needs to be done is that saphenous branch. So it's pretty easy to anesthetize for ankle and foot surgeries right there. So if you got somebody that doesn't want general or whatever, like me, that's the way you can do it easily. So there is the fibular head. There is the common fibular nerve going just around the neck. And it's going to branch into, again, the deep component. There's the deep coming around to the anterior compartment, and the superficial going around to the lateral compartment. Okay? So that's those guys. So there's the deep in the anterior compartment, and he does do you remember which guys are in the anterior compartment? Tibialis anterior, very good. That's this guy right here. There's tibialis anterior. Hallucis longus is this guy coming down to the big toe, and then, what's the other one? Digitorum. So you got extensor digitorum coming to the toes, toe extensors, extensor hallucis, big toe extensor, and tibialis anterior comes over medially. So what do these guys do collectively? What's their main function? All dorsiflexion, okay? So they all dorsiflex, in other words, raise the toe, if they are on this side of the midline, if you will. They will also assist with inversion, and if they're on that side, they will assist with eversion. So digitorum, and I know we're getting away from nerves here, but digitorum has a specialization on it called, do you remember? That also assists with eversion, a separate guy called fibularis tertius. You don't remember that? That's kind of a cool little thing. That's why I thought you'd remember that. Sorry. Okay. So then the superficial in the lateral compartment goes to the fibularis longus and brevis, right, that go behind the lateral malleolus. And what do they assist with? What do they do? Evert and plantar flex, because they go posterior to the medial, posterior to the lateral malleolus. So they assist us with plantar flexion. So the other axis, we got this axis, and if we're on this side, we do that side, we do that. We got this axis, and on that side, we come up, and the other side, we plantar flex. So there is the superficial, its cutaneous distribution, right? So the superficial branch coming out of the lateral compartment gets its two muscles, and it becomes cutaneous to most of the dorsum of the foot, except for the space between the great and second toe, and that's the deep branch, right? So that's the cutaneous distribution of those guys. Ankle block, we need 5 sites. We don't really need to worry about that, but I'll just zip through that. You don't worry. I'm just trying to compare the two. So what do we have here? An ankle. Very good. What side of the ankle? Medial side. So we're 2 for 2. And what else do we have in that medial side of the ankle that may be of importance? How about Tom, Dick, and Harry? Right? Tibialis posterior, digitorum, and hallucis longus tendons. With with Ann and Nancy in between. Yeah. Something untoward going on there. So anyway, then we get down into the foot, and we've got the medial plantar and the lateral plantar, which are branches of the tibial. And the medial plantar is like which nerve in the upper extremity? Like the median. In other words, it gets 3.5 digits. In this case, the medial 3.5 digits, because our lower extremity is internally rotated. Upper extremity is laterally rotated. So the thumb and the big toe are the same guys, if you will, developmentally. So the median is lateral 3.5. The medial plantar is medial 3.5, right? And then lateral plantar, like the ulnar, gets most of the muscles, but less of the skin. So the same kind of thing going on there, only 1.5 digits. So, dermatomes of the lower extremity. So we're going to have testing using the dermatomes, or the sensory distribution, single spinal segments, again, the same way. So on the medial side of the foot is L4. What's the named nerve that carries that there? Saphenous. So again, the saphenous is a branch of the femoral. The femoral's got L2, 3, 4 in it. But by the time the saphenous gets down to the medial foot, it's bringing L4 there. So that's how the dermatome stuff works. So, whoops, you're coming too soon. Sorry about that. What's the top of the foot? So that's going to be remember the superficial branch, right, of the common fibular does most of it, except for the space between the great and second toe. But what's the dermatome here? That's 5. So there's L5. And then the lateral side, I don't know how I did that. I got all these things mixed up here. Lateral side is going to be S1. So sticking to the dermatome again, on the foot, L4, L5, S1. That's like what we did with the hand. Why do we go to the foot? Again, get as far away so that they're mostly separated. Just like going to the hand, 6, 7, 8. Go all the way down to the foot, and you can test the dermatomes effectively there. So now, motor function. L4 is knee extension for the most part. Remember, we've got the femoral nerve that is responsible for knee extension, right? And it's 2, 3, 4, but the main guy, again, the main guy affecting knee extension is 4. So if you got numbness on the medial side of the foot and weakness of extension at the knee, it's an L4 lesion. So big toe extension, so there's not a good reflex. You know, you got a great reflex with the quadriceps reflex. You got a great reflex. If that's absent, you know it's L4. But we don't have a good reflex for L5, but big toe extension is predominantly L5. And you can actually elicit a reflex with that too if you're really good, if you're J. Kelly Smith good. And then Achilles tendon reflex is S1. So there's L4, 5, and S1, sensory/motor. Okay? Got it? Okay, so let's see how well you can handle this. So we got a 37-year-old into the emergency department, motorcycle accident, or I call them donor cycle accidents. X-ray taken, fractured pelvis, produced a lesion of the femoral as it crosses. So the femoral, once it gets into the thigh, you can't lesion the whole nerve. Right? And I told you stories about that. So it's got to be high. It's got to be either in the pelvis, and that happens a lot with pelvic retraction surgeries when you're trying to pull things out of the way and you just happen to grab the femoral. So that happens. But in this case, this guy's got a pelvic fracture and the femoral nerve is damaged. So what of these things will be, and they could be multiples, what will be affected here? So will you have loss of cutaneous sensation to the lateral thigh, yes or no? No, why not? That's lateral femoral cutaneous, so you don't have that. Anterior thigh. Okay, so we got that guy. So cutaneous sensation, lateral leg and foot? No. What about medial leg and foot? Yes, via saphenous. Loss of extension at the hip? No. Why not? Doesn't do that at all. Your big extensor is your gluteus maximus, and the hamstrings extend, etc., so it's not that. Extension at the knee? Yeah, that's big dog. That's important. Loss of flexion at the hip? Not loss. It'd be weakened. You got your major hip flexor, which is iliopsoas. Very good. So that's not lost. Loss of flexion at the knee? No. Would it be affected at all? Sort of, right? Sartorius, okay? But not lost. Loss of quadriceps reflex? Yeah, so that's that. Loss of Achilles tendon reflex? No. So that's an S1 thing. That's downstream. So not that. Good. Oh, let's see. So here we've got a 37-year-old guy, came into the emergency department. He's got a football injury. He was cutting through the line while he felt a pop in his gluteal region. Immediate pain, couldn't tell any other problems initially, but some have appeared. MRI, he's got inflammation deep to the gluteus maximus in the area of the piriformis, right? Appears to have produced a lesion of a nerve. What nerve are we talking about? No. Be more specific. If the piriformis itself is, unless it's severely swollen, it's not going to affect the sciatic per se. What can it affect? The common fibular coming through it. And this happens. This is not, my making stuff up here. So it's a common fibular. So which symptoms are we going to have with this? Loss of cutaneous sensation to the dorsal foot? Yes. So we got that. What about plantar foot? No. Loss of eversion of the foot? Yes. We're going to have loss of eversion because this is the common fibular. Common fibular is deep to the anterior compartment, and it's superficial to the lateral compartment. And the lateral side of the anterior guys do eversion, and the two in the lateral compartment are everters. Loss of inversion of the foot? No, but it could be slightly weakened because your tibialis anterior would be affected, and that's an inverter, but not lost. Weakened extension at the knee? Doesn't do anything at the knee, folks. Weakened flexion at the knee? Weakened flexion? So this is common fibular? Wrong sides. Common fibular does anterior and lateral compartment, unless, why would you say weakened? It says at the knee. It gets the short head of the biceps. Very good. So slightly weakened, but that's good. So that's the one thing that's kind of out of sync here. Weakened flexion at the knee? Wait a minute. I did the wrong one. I'm sorry. It should have been that one. Okay. Weakened dorsiflexion. Moving right along. Weakened dorsiflexion. Okay. We got that. Weakened plantar flexion. Yes. Because the lateral compartment. Okay. Weakened flexion at the hip. Trendelenburg sign. What's Trendelenburg sign? I just threw that in. So that's, which nerve is it? Superigluteal. Superigluteal, right? Superigluteal supplies what? Medius and minimus. What do? So they pull down, let's say this is the side we're talking about. They pull on the hip, right? Pull down on the iliac crest, pull it down, or they abduct, right? So if you transfer that to this, that's what they do. But what they really do is stabilize the pelvis when we walk. So if I raise this foot, my pelvis is stabilized by the guys on this side. So if I lose the superior gluteal nerve, I lose that ability to stabilize it, and I dip to the opposite side. That's Trendelenburg sign. It's also called dip gait. So you dip to the opposite side. Dip to the opposite side. Okay? Yeah. Yeah. So this is just if the common fibula were damaged. The simple way to ask the question. Okay, so now we got another guy. He's got his knee in the cast. He's a running back, hurt his knee while returning a punt, hit on the lateral aspect of the knee, fractured the fibular neck. That's what's suspected. Your physical exam demonstrates positive foot drop, numbness on the dorsal aspect of the foot. What's happened? So the fibular nerve is damaged. It could be due to a fibular fracture, neck fracture. It also can be due to a cast that's too high. So improperly casting so if you got an ankle fracture and you put the cast too high, you can have somebody that comes out of the cast with foot drop. Unfortunately, that's all too common for folks that don't know. So my recommendation is with your patients, don't send them when they hurt their ankle to, no offense, but a doc-in-the-box kind of place, because they're not really skilled in doing that kind of thing. So anyway, okay, changing gears just a little bit. We're in good time. Which of the following ganglia does not contain postganglionic parasympathetic neurons? And Cody, the answer is? The answer is celiac. Okay, so the other, so what is the celiac? It's a sympathetic, and where is it? It's in the abdomen, so it's part of the sympathetic portion of the autonomic nervous system, and the other four are part of the parasympathetic portion of the autonomic nervous system. So the submandibular, what nerve is it associated with? Let's talk about cranial nerves. So submandibular ganglion is associated with, there are 12 cranial nerves. Are we going to name them all? So what cranial nerves? Let's go back. What cranial nerves have parasympathetics associated with them? 7, 9, and 3. So you got 3, 7, 9, and the big guy, 10. So 3, 7, 9, and 10. So which of these 4 here, let's forget this guy because he's our answer. So which of these is 3? So 3 is there. Which of these is 7? Submandibular is 7, and pterygopalatine is 7. Which one is 9? The one remaining guy. So 10 isn't on here, but we'll see about 10 shortly. Okay, so there's our answer. Got it right. So the point is you got to know what's going on with ganglia. First thing is all ganglia, whether they're parasympathetic, sympathetic, or somatic sensory, right? The ganglia associated with all of your spinal nerves, those cell bodies are all derived from neural crest. And that can show up on these exams. So they're all ganglia, whether they're parasympathetic or sympathetic or whatever. They're all derived from neural crest. So neural crest cell migration issues can cause problems with these ganglia getting to where they should go. There's one particular clinical syndrome or situation or disease that likely has a root with improper neural crest cell migration. Do you know what that is? Very good. Hirschsprung's disease or megacolon. Very good. So that's failure of these guys to migrate into the descending colon, et cetera, the hindgut. Very good. Okay, so that's what we're going to go over. Yeah, shaking our head. So obviously we know what this is. This is a sagittal cut through the head with various ganglia that we're going to talk about. And again, I've got one of my things coming up too soon, so sorry about that. So here we go with these guys. So parasympathetic ganglia, what's that? That's the ciliary. So ciliary is associated with, again, cranial nerve 3. So ciliary ganglion, cranial nerve 3. What does it do? What's it for? Give me a general category. There's a name for what it does, what it's responsible for. There are two things that it does, but they fit into the category called accommodation. So accommodation. So if I'm looking back at the clock and I see it's only 11:18, we got a lot of time till the stuff starts. So accommodation, if I look there and then I try to read what she's writing up here, I am accommodating. And there are actually a few things that happen with accommodation. One is your pupil constricts. That's one, right? Your lens balls up, gets thicker, if you will, so that you can focus better. You constrict the pupil so that you've got less light coming in and you can focus better because it's more specific. And again, balling up of the lens. And the third thing is you adduct your eyes. You converge. So those three things happen, and this guy here is responsible for 2 of those 3. So he will go into the ciliary body, right? And the ciliary body is a sphincter, and the sphincter constricts, and it connects to the lens of the eye. So if I can try to draw this. So if this is the lens of the eye, yeah, that's not very good. It's connected to the ciliary body. I went out too far. So that's the ciliary body right here, the muscle. And if we do it in this fashion, here's the ciliary body. It's a sphincter. And these are zonular fibers that connect to the lens. So if that sphincter constricts, in other words, gets smaller, its radius, its circumference, so now it's in here, let's just say, then the zonular fibers release the tension on the lens, and the lens balls up. Okay? That's one of the things that happens. The other thing that happens, and if you can figure that out from my drawing, you're good. And the other thing that happens is the iris, the pupil constricts. So the pupillary muscles constrict. And so that closes off. So that's one guy. Accommodation. Important. What's this guy? That's the pterygopalatine. Associated with which nerve? 7. Okay? Pterygopalatine associated with cranial nerve 7. What does it do? Kind of, again, back to general rules. What does it do? Where is it? If you know where it is, it'll tell you what it's doing. It's deep in the face. It's right behind the maxilla and all that stuff. And so what it does is it supplies the mucus glands of the oral cavity, the nasal cavity, and our sinuses. Maxillary sinus, for example. When those things fill up, it's because these glands are going crazy on us now. Okay? So that's what's going on with that guy. Everybody okay with that? So you see the branches coming down to the mucosa that would be here over the hard palate going into the nasal cavity. Those are lateral palatine branches. Imani, I am not answering your question.
It might be dumb, but so on some of these,
Can I tell you if it's dumb? No.
on some of these we would have two ganglia, right? Do we have two pterygopalatine nodes?
Yes.
Or kind of big
One on each side.
ones? Okay, cool. That was my question.
Yes, we do. That's not a bad question. It's not a great question, but it's not. So the next one is submandibular. Associated with which nerve? So it's associated with which nerve? What's it hanging from? So this, what you're telling me is this guy is cranial nerve 7. That's 5. Wow. So you're lying to me. You told me that it's associated with cranial nerve 7. But this is cranial nerve 5, right? What's that branch called, do you know? Lingual. That's the lingual nerve, the lingual branch of cranial nerve 5. So how do you get a ganglion associated with the lingual branch of cranial nerve 5 when the ganglion's associated with 7? Hitchhike, right? Hitchhike via, what's hitchhiking? Chorda tympani, okay? Remember all that stuff? So here you can see chorda. So this is cranial nerve 7 right here, going in the internal auditory meatus along with cranial nerve 8, 7 and 8 together. Remember acoustic neuromas? Very important. Acoustic neuromas, 8th nerve lesion, commonly occur at the internal auditory meatus, not only affect 8, but also affects 7. So there's 7 coming in shadow here. And there it is coming to come out, stylomastoid foramen, 10 zebras bit my cat, right? And here is the branch off of 7 that is chorda, that now joins with lingual. Okay? So, what's that ganglion going to be responsible for? What is that ganglion? Why do we have that ganglion? What's it for? Be specific. Submandibular and sublingual salivary glands, right? So submandibular and sublingual, submandibular, this big guy here, and sublingual just under the tongue. So cranial nerve 7 via chorda tympani travels with the lingual synapse in the postganglionic guys here, in that ganglion, and travel to those glands. Okay, so getting a little crowded here. Let me clean that up. So what's that guy that I just put in there? Otic ganglion. So that's the otic ganglion. Is everybody okay with that? So how did you know that's the otic ganglion? Because process of elimination, huh? That's what you're down to. You got 3 others and there were 4, so that's the otic ganglion. What's that part of? What cranial nerve? So that's part of 9. That says 8. What? Just checking to see if you're paying attention. So that should say 9. Sorry. God. What happens when you do something at like midnight and you're old and decrepit and yeah. So anyway, that's 9. I got a few things to fix if I ever use this again. So there's cranial nerve 9. So what does it do? What's it responsible for? Parotid. How does it get there? You remember? Do you want to even think about that? So this is too long, but 9, cranial nerve 9, where does it exit the skull? Jugular foramen, along with other nerves. 10 and 11. So 9, 10, 11 come out the jugular foramen, along with IJ. 9 sends out a little teeny branch called the tympanic branch. And it goes through the tympanic canaliculus. It's right between the carotid opening and the IJ opening. So it goes, there's a little ridge of bone there. It goes right back in. It's a tiny little guy. It supplies sensory into the middle ear cavity. Does that. It supplies the dura in that region. And then the fibers that aren't sensory go out the middle ear and travel on the base of the middle cranial fossa as the, anybody remember what it's called? Lesser petrosal nerve. And lesser petrosal then goes out foramen ovale, which is right there, foramen ovale, or foramen spinosum, or an unnamed foramen between them. Synapses in this guy, travels out the, you know what nerve it hops on next? You'll remember when I tell you. So the nerve comes through here, right, as lesser petrosal. Synapse is there and hooks on, oh, it's in there. This nerve, which goes around the middle meningeal artery and then goes to the parotid gland, right? The auriculotemporal nerve. Remember there was a nerve that went around the middle meningeal artery? You probably remember that, but that's called the auriculotemporal branch of 5. Okay, so that's that. Okay, so sympathetic. That's my other thing down here. Sympathetics to the head and neck. So we talked about all the parasympathetics. What about sympathetics to the head and neck for fight or flight? Where do they come from? Superior cervical ganglion, and that's that guy right there. Okay, so there's the superior cervical ganglion. Again, postganglionic cell bodies derived from neural crest. Okay? Also derived from neural crest. But they are in this superior cervical ganglion. So where do they go? What do they supply? It says sympathetic to the head and neck. Is that kind of summary there of that whole thing? So sympathetic ganglion, superior cervical ganglion. So they go to the head and neck. They also go to, we also go to C1, C2, C3, and C4. So from here, you got a good view of this guy. Let me clean it up a little for you. And here's the important one. So you see this coming off? Right there? What's that called? It's coming off the top of the superior cervical ganglion. It's called the carotid nerve because it's on the internal carotid, right? So that's the carotid nerve. Now here's the cool part, and you'll remember some of this. So those are postganglionic sympathetics. They travel with the internal carotid. Where does the internal carotid go next? Very good, cavernous sinus. So what's in the cavernous sinus along with the internal carotid? Cranial nerve 3, 4, 6, V1, V2. Sympathetics can hop off this and go to those and get distributed on those guys. Additionally, the carotid sends branches into the head and neck stuff, and it carries some of those branches, some of the sympathetics with it. So the sympathetics can get onto nerves and travel to where they're going via the nerves. The sympathetics can travel on the blood vessels to get to where they're supposed to go. Okay? So that big guy there. Additionally, a lot of these little branches that don't seem to go anywhere, they go on to C1, C2, C3, C4, those cervical nerves in the cervical plexus. All right? So it supplies everything to the head and to the neck region. So that's what's going on with that guy. And we got more stuff. Sensory ganglia. So again, I want you to realize that your sensory ganglia also are derived from neural crest. And they're distinct from, separate from, the parasympathetic and the sympathetic that we just talked about, right? But in order to be kind of complete about this, so what's that? That's the big trigeminal, okay? Huge sensory ganglia. So no synapses in these, unlike the parasympathetic that we just talked about, or the sympathetic. These are just sensory ganglia. So the way they develop is the neural crest cell migrates into a place, it gets located in this ganglion, and it sends out a peripheral fiber that goes to whatever sensory receptors it has, and the central part goes into the central nervous system. Whether they're associated with cranial nerves or they're associated with spinal nerves, they develop the exact same way. And then the other thing that happens is the nerve migrates a little bit away from the nerve itself. So instead of having that configuration, it'll look more like this. It'll have a connection like that. So that's the way these guys develop. And the reason that happens is so the impulse can go straight from the receptor to the central nervous system without having to go through and be interrupted by going through the cell body. Okay, so that's how those all develop. And those are all the sensory ganglia, whether we're talking trigeminal here or any of the other guys. So there's trigeminal ganglion, big guy of cranial nerve 5, big sensory cell bodies, no synapses, all derived from neural crest. Okay? What's that? A little hard to kind of tell what we're pointing at there, but do you see that? So I'm pointing at this enlargement there. Geniculate, associated with, geniculate. That says geniculate. Wow. This is about 2 in the morning, I guess now. Geniculate, I'm sorry. Geniculate. What does genu mean? Geniculate, what does it mean? Bend. So you can see the bend. In which nerve are we talking about now? So let's see what shows up. Whew. Whew. Got that one right. So there's the sensory bodies, cell bodies of 7. What do they do? What does trigeminal do? Let's go back to what trigeminal does. Face, right? So V1, frontal nasal prominence, I should have showed you this. Frontal nasal prominence, V2, maxillary swelling area, V3, mandibular swelling. That's what 5 does. So what does 7 do? What does 7 sensory do? It does muscles of facial expression. 10 zebras bit my cat. What does sensory 7 do? So it does taste for the anterior 2/3 of the tongue, right? Everybody okay with that? But it's also got a variety of other places that it's sensory from. Sensory from the dura, sensory from the ear, pinna of the ear, a variety of other things like that, okay? So that's what 7 does. So what's this guy? The glossopharyngeal ganglion. There are 2 of them. There's the superior and an inferior, and you can see that's pointing to the superior. And they go to, so these guys, sensory cell bodies of cranial nerve 9, so glossopharyngeal, right? So what does that do? So that's sensory, that's taste, to the posterior 1/3. It's also general sense from the posterior 1/3. So you got taste, you got a special sense, and you got a general sense. Now that's kind of weird, right? From the same part of the tongue. And the interesting thing is the taste fibers, their cell bodies, this is more than you need to know, but I'll tell you anyway. Their taste fibers are there. The general sense fibers are up here in the superior ganglion. Okay? And then the next guy, so that's what I just said. And then the vagus, so this guy is the vagus, right? So we're talking about cranial nerve 10, and it's got the same situation. It's got a superior and an inferior ganglion with the same kind of situation like that. The superior one will be from places like the root of the tongue, from the dura, from the pin of the ear again. So anything that's a general sense. In the lower ganglion will be the taste guys. In the case of cranial nerve 10, all of that stuff that we have coming from the abdomen, if we've got any stretch receptors, etc. So that's what's going on with that. Okay, so the inferior ones, general visceral afferent kind of things, which you may have gotten that terminology in neuro. So sympathetics, getting to complete the loop on these. So sympathetics to foregut, right? Fight or flight, all of that stuff. What they're doing at that point in time, they're doing a variety of things, but you can imagine if you're in fight or flight mode, what you don't need is your gut spending all its time and energy digesting food, which kind of slows you down and gets you lazy. That's why you've got to, eating before you work out, according to some people, isn't a bad thing, but it's a little hard to get ramped up. So, and that's because your blood is doing all this stuff. So you got to get your sympathetics cranked up so you actually reduce blood flow to the organs. You increase blood flow to these things, and that gets you into fight or flight mode. So where did I put my clicker here? So that's what's going on. So what is that? So there's one of the sympathetic ganglia down here. That's the celiac. So what comes into the celiac ganglion? Greater splanchnic. So there's the greater splanchnic, and that's from T5 to 9 off of the sympathetic chain, and it's coming down there. So it's your splanchnics are going to viscera. Splanchnic's going to viscera. So that's what's happening here, and he supplies foregut. Who supplies midgut? So your superior mesenteric is going to midgut, traveling out the superior mesenteric artery to all of its component parts. Who supplies hindgut? So you got hindgut gets a little goofy. Now, hindgut gets a little goofy. The hindgut are these right here. They are your lumbar splanchnics. So they go out on the inferior mesenteric artery and supply hindgut, like we said. These supply midgut. So, and then some of those lumbar splanchnics descend to go down into the pelvis to augment the ones that are in the pelvis, which are going to be down here, which are your sacral splanchnics. Whoops, ran out of room. And they're going to be sympathetic. So you probably won't have a lot of detail on that, but just to complete the loop with that question that Cody asked me about, which of these are which kind of ganglia. So I think that's all I've got. So that's, the only other thing is I put in here cranial nerve 10, which is going to be down here, parasympathetic, for homeostasis. All right, we're done. Yay. Yeah. Don't applaud, just send money. So go out, have fun, get some food, chill. You're going to do fine.
Will you upload that with integrity?
It is. That's what, what?
Well, I know, but you gotta like.
Oh,
stop
do you know
it
how to
and-
do that?
No, don't you? I think you have to stop it first.
Stop it.